we are in this meeting by AstraZeneca regarding the recent updates in gynecological cancers. So there are three topics to be dealt with. One is that we need to discuss about some updates in gynecological cancer. Dr. Darshit Shah and Dr. Muzammil Shaikh will be giving their talks on two topics: latest NCCN guidelines and also paradigm shift in the management of ovarian cancer. And in between these two talks, we are going to have a panel discussion on how to manage the toxicity involved with the PARP inhibitors. So without much ado, I would request Dr. Darshit Shah to start his presentation on the latest NCCN guidelines in the management of ovarian cancer and what's new in ovarian cancer research. Dr. Darshit Shah, please. Dr. Darshit?
So he has not yet logged in, sir.
Okay, so will be then what do we do? Can somebody contact him?
Yes, sir. He said that he'll be logging in sometime, sir.
So do we wait for him or do we start the next
So we can go
session?
ahead with the next session, sir.
Sorry?
So we can go ahead with the next session, sir.
You mean the case discussion?
Sir,
Yes.
Dr. Darshit has joined.
Okay, thank you, thank you. So Dr. Darshit, have you joined? Hello, Dr. Darshit.
Hello, good evening, sir.
Have you joined?
Yes, sir.
So can you start your presentation, please?
Yeah, just a second, sir. If
Okay.
somebody can share the presentation, sir, will it possible for the team to share the presentation, please? Thank you so much. So, good evening, everyone. I would be presenting regarding the latest NCCN guidelines in the management of ovarian cancer. So, the management of epithelial early stage ovarian cancer, stage 1. Next, please. So, this is the, we all of us know the preferred regimen across the globe, and everyone's preferred regimen is paclitaxel carboplatin every 3 weekly, high grade serous, clear cell, or carcinosarcoma. Next, please. So, the NCCN recommendation is like if the patient is having suspicious abdominal mass or pelvic examination abdominal nodes, we have to work up. I mean, the routine examination, CA 125, the imaging wise, if stage 1A fertility is desired, the primary treatment is unilateral salpingo-oophorectomy plus surgical staging. 1B, it's bilateral salpingo-oophorectomy plus comprehensive surgical staging. Stage 1A to 4, optimum cytol reduction is likely is required when fertility is not required, which includes hysterectomy plus comprehensive staging and debulking. So, with patients of ovarian cancer, fallopian tube, or primary perineal carcinoma, definitely should undergo a genetic risk evaluation in germline and somatic testing if previously not treated. Next, please. So, following treatment, patients undergo surveillance to monitor for recurrence. So, NCCN recommends serial visits, including pelvic examinations, measurement of CA 125 if initially elevated. Imaging is only recommended if clinically indicated. So, SGO guidelines has emphasis on symptom assessment and physical examination. So, the examination, physical examination are the cornerstone for post-treatment follow-up. We can see that physical examinations every 4 to 6 monthly for 3 years, and then annual physical examination is recommended. Next, please. So the management of epithelial ovarian carcinoma stage 2 to stage 4. Next, please. So the guidelines, if the tumor is resectable, we undergo tumor reductive surgery. If it's unresectable, then we have to give chemotherapy, neoadjuvant chemotherapy, preferably paclitaxel, evaluate for IDS, post 3 cycles, and then adjuvant chemotherapy. Next, please. So these are the NCCN recommendations. I think baseline. We have to test for BRCA. If no bevacizumab is used during primary therapy, if the patient has achieved CR or PR, if BRCA is germline or somatic BRCA mutation is known, then we have to consider olaparib or niraparib. Niraparib is not available in India, which is category 1 recommendation, olaparib. If the BRCA is wild, we can observe the patient or niraparib or rucaparib. If the patient has used bevacizumab as a primary therapy in patients of germline or somatic BRCA mutation, we continue bevacizumab and olaparib according to PAVLA trial. Uh, you know, this is a category 1 recommendation. Next, please. Next, please. So the PARP inhibitors approved in US, olaparib is the first PARP inhibitor which was approved in 2014 and used as a monotherapy or a combination therapy. We had so many discussions across numerous forums regarding the use of olaparib, the data, the side effect profile. It is the most preferred option, despite we have other options like rucaparib and niraparib. But my first preferred option is always olaparib. If the patients have germline BRCA mutated, and we have enough and strong data to back up and we have enough experience regarding the use of olaparib. Next, please. Next, please. So, the evidence suggests a successful cytoreductive surgery is associated with improved survival. So, we always ask for R0 resection, optimal cytoreduction. So, the meta-analysis reported that expert centers have high optimal rates of cytoreduction, and optimal cytoreduction equaled an increase of mean weight survival time of 11 months. That is 50% increase. And each 10% increase in maximum CRS equaled a 5.5% increase in median survival time. So platinum intensity was not found to be statistical significant. Next, please. So the patients who are poor surgical candidates or unlikely to achieve optimal CRS should undergo neoadjuvant chemotherapy prior to surgery. So all of us would agree that platinum-based chemotherapy is predominantly used for stage 2 to stage 4 advanced ovarian carcinoma in anesthesia intent. Bevacizumab containing regimens should be used with caution due to potential interference with post-operative healing. Next, please. So, following surgery, patients receive adjuvant paclitaxel every 3 weeks, which is the standard of care. We all know the doses of paclitaxel and carboplatin. Next, please. So BEV may be used alongside primary chemotherapy and as a maintenance therapy following chemotherapy with advanced ovarian carcinoma. So the patients who have been started on bevacizumab may be continued on bevacizumab at least for 1 year, at least for 17 to 18 cycles. Next, please. So the dosage of bevacizumab varies. Some in Icon 7, it was 7.5 milligram per kg, and in GOG 218, it was 15 milligram per kg, which was used bevacizumab. Next, please. So olaparib is a maintenance therapy for patients with stage 2 to stage 4 disease or germline or somatic BRCA with complete or partial remission following therapy, regardless of BEV, whether BEV was used during primary treatment. Next, please. Next, please. So maintenance of management of relapsed or recurrent epithelial ovarian carcinoma. Next, please. So if it's a platinum sensitive recurrence, we tend to re-challenge the same paclicarbo. NCCN defines as more than 6 months after completion of platinum-based chemotherapy. The ESMO recommends more than 12 months. Partial platinum sensitive is 6 to 12 months. Platinum resistant relapse is less than 6 months. And platinum refractory is cancer progressing during therapy or less than 4 weeks after completion of platinum based chemotherapy. Next, please. So management of patients with recurrent disease is dependent on sensitivity to platinum based agents. Next, please. Next, please. So, surgery may be considered for some patients with recurrent disease. So, secondary CRS can be considered for patients who recur after long DFI. However, it is not recommended in PSR patients who have biochemical relapse or who have biochemical relapse, that is platinum sensitive relapse. Next, please. So, re-challenge may be an option who have platinum sensitive disease. We prefer combination of platinum-based chemotherapy first recurrence with clinical or radiological relapse. Platinum inhibitor monotherapy is recommended as treatment options in patients with BRCA1-2 mutation, and maintenance BEV can be continued if used in conjunction with chemotherapy. Maintenance PARP inhibitor can be administered, but I would prefer getting the disease in remission and then considering the maintenance PARP inhibitor. Olaparib, rucaparib, or niraparib. Next, please. I think we have discussed this. The other options which are preferred is liposomal doxorubicin, gemcarbo, irinotecan, bevacizumab. These are the preferred option, as well as olaparib, the PARP inhibitor in the later lines. Next, please. This we already discussed the options, 2 or 3 lines we have, which include docetaxel, etoposide, gemcitabine, pegylated liposomal doxorubicin. Next, please. Next, please. So to summarize that cure is the ultimate treatment goal for patient with ovarian carcinoma, which is not always possible. Management of advanced ovarian carcinoma requires multidisciplinary teamwork, which involves all the surgical teams and medical oncology teams working in hands in hand. Treatment of early ovarian carcinoma includes surgery and adjuvant platinum-based chemotherapy, and stage 2 to stage 4 BRCA mutated disease with complete or partial response have a very good OS and PFS advantage with olaparib. We have discussed regarding the relapse set ovarian carcinoma. So that's all from mine. Thank you so much. Thank you for giving me the opportunity.
Thank you, Dr. Darshit. Thank you very much for your presentation on the latest NCCN guidelines in the management of ovarian cancer. Um, so, can we start with the uh, panel discussion, if it's okay with the organizers?
Yes, sir.
Yeah, okay. So the next part of this meeting is to do a panel discussion on the on managing toxicity with PARP inhibitors. So we are all now using PARP inhibitors more and more because of now availability of olaparib, both the original molecule and also the generic molecules which have come in India in the last couple of years. So we are all using more and more PARP inhibitors, not just for ovarian cancer, but also we're using for other cancers like prostate cancer, breast cancer, pancreatic cancers, and all. Because they're testing the genetic BRCA1, BRCA2 mutations, with testing more. So we have to also learn how to manage the toxicity of PARP inhibitors. And this panel is basically on discussion in managing toxicity of PARP inhibitors. So I would request the panelist, Dr. Avinash Dev. Are you there? Dr. Dev?
Sir, you will log in soon, sir.
Okay. Dr. Darshit is there. Dr.
Yeah.
Shivam Singla?
Sir, I'm
Sir.
here.
Okay. Hi, Shivam. And Dr. Sekar?
Yes, sir, I'm here.
Okay. So 3 panelists are there. So I think we can start the discussion and Dr. Avinash Dev can join in. Please let us know when he joins in so that we can ask the questions to him as well.
Yes, sir.
So do you want me to share the slides? Can I share the slides myself?
Yes, sir, you can do that, sir.
Okay. So allow share. Right. Can you see my slides here?
Yes, it is visible.
Okay. So just a brief case which has been given to me for presenting a 79-year-old lady patient with the BRCA1 mutation positive, presented with ascites, large mental mass, high-grade serous cancer on biopsy, high CA125, received chemotherapy, interval debulking surgery, and then again more adjuvant chemotherapy. And then after that, the patient was put on olaparib, a maintenance treatment olaparib because of initial heavy burden of disease. So with the olaparib, the patient then had obviously low hemoglobin anemia was there. Patient was given 2 minutes blood transfusion. Again, restarted olaparib at a lower dose. Dose reduction was on 250 milligrams twice a day from 300 twice a day. But again, had to be given blood transfusion. And this kept on happening. The dose was reduced to 200 milligrams twice a day. And then the patient completed 2 years of treatment. And then after that, the patient has been well. Now, this case presents 2-3 features. One is that dose reductions have happened because of side effects, and secondly, whether dose reductions are as effective as the original dose. So these are what we have to discuss in the next few minutes. In the next few minutes, this panel discussion. So the first question, let me start with Shivam. Shivam, what are the challenges which you face when you prescribe Linpraza or olaparib in your clinical practice?
I think the first challenge that I face is the performance status of the patient in terms of hemoglobin, because one of the biggest challenges, the full dose I'm not able to give to majority of my patients. Majority of these patients do land up with a lot of cytopenias because they have been given 6 cycles of chemotherapy prior to constitution of olaparib. The second challenge is with Linpraza is the cost, sir. For majority of the patients with the original molecule, the cost remains a challenge. And the third is that patients complain of a lot of fatigue once they start on olaparib, and when I give them the lower dose, they just don't want to escalate the dose to a higher dose. They always come tell me that, sir, this is the dose which is suiting me. So these are the challenges I face, sir.
So you said cost, anemia, and fatigue. Darshit, in your practice, what challenges do you face?
Yes, sir. So predominantly, as Dr. Shivam already mentioned, that predominantly it's the fatigue and anemia, which happens for majority of our patients, sir. So they are not able to take the full dose. So I usually start with a half dose, and then if they are tolerating well, we may consider escalating, sir.
Right. And Dr. Sekar?
Sir, I also agree with the other panelists. One thing challenging is HID testing in our population, which is quite difficult because of the cost. Apart from that, while giving the drug, I often feel the patient anemia and dose titration is one of the challenging side effects because majority of the patient travels from outside, and titrating dose and finding optimal dose for such patient is a difficult scenario. And second thing, frequently I encounter is the fatigue is the complaint. And third issue, sometimes patient complain about nausea. And I have encountered some cases of patients complaining about mild hair loss. These are the few encounters which
Okay.
are made with.
Hair loss as well. Right.
Yeah.
So I think one question which I feel is important for us, all of us to understand is, do we start with the full dose or do we start with a low dose to start, initially? Because guidelines says that you start with a full dose and then you reduce the dose depending on the toxicity. But to tell you frankly, in my practice, I'm hardly able to start the patient on a full dose, 300 milligrams twice a day of olaparib, right? So can I ask Shivam? Shivam, in your practice, how many patients would you start with the full dose and then reduce, or how many patients do you start with a low dose and then try to increase?
Sir, 80% I start with the lower dose and then increase. Only younger fit females who come between the age of less than 40 years, 50 years, then I start with the full dose. Otherwise, 80% is start with the lower dose, 150 mg twice a day, and then gradually increase.
At 150 twice a day. Darshit, in your practice, what is the ratio? Shivam said 80-20.
Correct, sir. So I usually start all my patients on 150 BD, sir. And I would say hardly, if I can remember, only one patient is taking full dose, but the rest either 300 or 450, sir. This is the patients, they are just tolerating this dose only. My patients.
And Dr. Sekhar?
So majority of the patients, I try to give adequate time for them to recover from the toxicity. So maybe after completion of adjuvant chemotherapy, I give 1 to 2 months of adequate interval. They recover from the full toxicity grade 1. And then I will assess the patient, what are all the toxicities they encountered during the time of adjuvant chemotherapy, whether they have significant cytopenia, thrombocytopenia, anemia, some complications of grade 3 is there or not. All those things I will monitor. And if they are young and they're comfortable, I am okay with starting with full dose. I'm not going and starting with half the dose. In such patients who are young, fit, not having much toxicity with adjuvant chemotherapy required on time, all those patients I'm starting with full dose. And reasonably good number of patients are maintaining in those population, maintaining with full dose also very well. In certain group of patients, especially who are more than 65, 70, who are having toxicities during the time of adjuvant chemotherapies and who are having prolonged time to recover or to reach the level of grade 1 level of cytopenia after adjuvant chemotherapy, in such patients I'm little bit more cautious. I have counseled them and then I start with at lower doses often, and then I try to escalate based on the tolerance.
Dr.
So
Sekhar, give me a percentage now, please. Either
percentage wise, maybe around 50-50, because
so
yeah,
50%
50-50.
patients you still start on a full dose. That's what you're saying.
Correct. Yeah, 50% at least I start on full dose. But our percentage of patients who are starting on PARP inhibitor is very less. That's right.
So, in my experience, I fully agree with Darshit that I always start with a, reduced dose to start with and gradually
No,
build up the dose.
so,
Because
but I
giving a
feel
full
that is
dose,
not
I
a
think,
ideal practice. Still, good number of patients, I feel they go ahead with full dose. That
right,
I
okay.
completely agree with.
So, yeah. So I think but this is important for us to understand that, some of us start with a full dose, some of us start with a lower dose. So the next question which I wanted to ask is that um, in the other TKIs also we have seen that most of the TKIs we have to reduce the dose, and the reduced dose also is equally effective. So what do you think about olaparib? Let me start, Shivam. Do you think when we reduce the dose, do you think we are doing a disservice to the patient by reducing the dose in terms of efficacy, or do you think that even the lower dose is equally effective?
Sir, I think one principle that I have learned with oncology is the maximum tolerable dose is the most efficacious dose. Higher dose leads to more discontinuation, and I think that is more disastrous for the patients. So I don't think Indian patients tolerate more than 450, sir. I have rarely seen. So our dose is for Indian patients between 300 to 450, sir. Maybe difference of kinetics. So I am made peace with the lower dose, continuous administration rather than higher dose with interruption.
And you also feel that the giving a reduced dose is not bad in terms of efficacy.
Sir, I've been only using this for the last year or so I don't know how it will span out in the future. But patients who are on reduced dose, their CA markers are equally good, sir. I don't see them to be jumping here and there, sir.
Darshit, in your practice, do you think reduction
Sir,
of dose is harming the patient?
no, sir. As Dr. Shivam rightly pointed, we need to continue the dose rather than getting frequent interruptions, and with more hospitalization and more toxicity, and poor tolerance is actually is very difficult for us also to counsel the patient. So I usually am comfortable with 150, or maximum I am okay with 450. Hardly, I mean, we go to 600. And as sir you mentioned it, there are so many examples. When we talk about lorlatinib also, like 75 or 100 or 50.
Yeah.
When we talk about abemaciclib also, the efficacy, the results are more or less similar, sir. And we don't have any major differences in terms of survival or response rates. So I think I personally agree that the patient should be taking olaparib rather than frequent interruptions, sir.
The reason why I brought this point was the quality of life. These are long treatments, and that's why the quality of life needs to be also very manageable, because otherwise the patient will stop taking the medicine. And it's not easy to, sometimes they say they take the medicine, but they may not be taking the medicine. The compliance can become an issue. So that is what Dr. Sekhar, do you feel reduced dose is okay, or what do you feel?
So this carries an opinion that if we start every patient with a reduced dose, there are good some amount of patients who require actually full dose, who tolerate with those full dose. We are not doing good justice for those patients. They may have the risk of recurrence also. That is what the abemaciclib also they say. Try to start with the full dose early, and then over a period of time you try to monitor for the toxicity. With respect to olaparib or PARP inhibitor, there are two ways of practice still they follow. One is to monitor for the how they tolerate the adjuvant therapy. That gives a clear idea how we are going to proceed with the maintenance PARP inhibitor. And second thing also is there that if you feel the toxicity will be more high, then consider for that patient initial 1 to 2 months start with a lower dosage and tries to gradually escalate to try to full dose and then see how they are tolerating the dosage.
Yeah.
These two things also I practice in routinely, and I think good reasonable amount of patients try to tolerate full dose. I don't completely agree that all the patients going with 400 to 350 mg. I don't agree with the point.
So I think overall, most of us would agree that giving full dose 300 BD is not, a routine. We somewhere down the line either have to reduce the dose, or we start to reduce and increase the dose gradually. That's what.
Yes, yes,
And
that is true.
so okay, let me ask again the three of you. Your current patients. Let me start with Shivam again. Shivam, your current patients, how many of them are a full dose, and how many of them are reduced dose?
So only one is on full dose. Majority of the patient, approximately 20-25, are on reduced doses.
Right, Darshit. Darshit, we can't hear you.
Sir, only one patient on 600, majority on 450 or 300, sir.
Right, and Dr. Sekhar?
So around 20 to 30% on full dose, and 50% required drug dose reduction, and 20% required dose discontinuation.
Okay, that's fine. So this is what I think overall the practice is similar, right? Now, the next is, I think we're just going to go through the different side effect profiles quickly. The commonest which we feel, I think, is anemia. If does everybody agree with that? Anemia is the most common side effect which we feel with olaparib and Linprada, whatever, right?
Yeah, we totally agree with that.
Right. So
Almost
I think
30%
this
we
is,
have grade 3 anemic toxicities in our population.
yeah. So anemia is one of the commonest side effects, less than, and the median, as per the solo trial and the other trials, I think the median duration was less than 3 months in all the 4 trials. And 18% of patients required at least one blood transfusion, and 20% of patients used iron preparations, and 5.9% of patients using erythropoietic stimulating agents. So these are the ways which we can counter anemia in our patients. That's what we normally do. Again, duration of neutropenia was less than, the median duration was less than 1 month. And how many of us have used growth factor support in managing neutropenia because of olaparib? Shivam.
Sir, neutropenia, not really. Anemia,
Yes.
definitely. So neutropenia, the counts are of 3,000, 2,800. I stop the drug. I don't give growth factors. For
Right.
anemia, I have used the factors, growth factors for hemoglobin, sir, erythropoietin and other things, but not for neutropenia, sir.
Not for right. Darshit?
Sir, I usually do not use GCSF for neutropenia. Definitely for low hemoglobin, I have used erythropoietin and the other agents. But neutropenia, I do not use, sir, GCSF for olaparib-induced neutropenia.
And Dr. Sekhar?
Neutropenia I hardly encounter with PARP
Yes.
inhibitor. And I have one interesting case. One patient whom I started with PARP inhibitor. Unfortunately, the patient lost to follow up. She didn't come on due follow-up date. And then she followed after a long period of time. She was continuing the drug. And she presented with the toxicity of anemia with a hemoglobin of 3 and platelet of 15. But still, the neutrophil count was normal. And she took very long time for the anemia and thrombocytopenia to recover. So that was one hard fact because we try to, whenever we start on these such drugs, we try to have a short follow-up in closely monitoring the patient. And the other thing is neutropenia is hardly seen. That's my opinion.
Yeah. Even I think the rates of febrile neutropenia are very low. We hardly
Yes,
see
it's less than
neutropenia
1%.
when we treat patients with olaparib. The most common is anemia, and then you've got thrombocytopenia. And I think most of us now, we know how to manage these side effects. Either we give blood transfusion, we give growth factors, we delay the
Sir, I have a question, sir.
dose.
Will you use erythropoietin for anemia in such patients if the patient is having anemia? What's your experience on
I don't
using?
use personally erythropoietin for these
Okay.
patients. Either I delay the treatment or dose reduce the treatment, or I give blood transfusion.
Because some of these patients in this trial have received erythropoietin, and
Yes.
we all know that erythropoietin have some tendency towards
Yes,
stimulating.
I don't use. I think
Yeah,
6% of patients use erythropoietin stimulating agents. So I don't use, especially
yeah,
in the
yeah.
adjuvant setting and all, because there is some data to suggest that it is not safe to be used. So I don't normally use. Right.
And with respect to romiplastim or eltromovac, your opinion when the patient is having thrombocytopenia with PARP inhibitors?
Again, luckily, the thrombocytopenia has not been that severe for us to intervene. Usually it's anemia which is the most severe problem. And that's why so far I haven't used even romiplastim or eltrombopag in our patients. Mostly it's anemia which has need to be treated. Right? I
Thanks.
don't know, Shivam or Darshit can also share their ideas on the use of romiplastim.
Sir, I let the platelet recover. Stop the
Yes, yes,
drug for some time, they recover again.
yes. No, normally it recovers and therefore you don't have to give, all these agents. Yeah. Now, coming on to incidence of MDS or AML, has anybody seen AML or MDS in patients of olaparib or Lynparza?
We have encountered with two patients with olaparib. One patient is heavily pre-treated, post multiple lines, and then we started with PARP inhibitor. That is the beginning, very beginning of introduction of olaparib. And then we started how to use and all those things. With current guidelines and current recommendation, we are hardly seeing this MDS in current practice.
Mhm. So, two patients in your practice, Darshit, Shivam.
Sir, I think it's very premature in my practice to see. Maybe in the next 10-15 years we may, but I have not seen yet, sir.
Okay, yeah. But even the incidence is very low.
Yes,
So
sir.
again, for us, for us to have so many numbers of patients to get MDS and all, I think it's unless we are really unlucky, then
I
unless
have
you
seen one more case with olaparib with ILD, interstitial lung disease, and that
sorry,
is also
olaparib with
unfortunate.
sorry,
Interstitial lung disease.
ILD. Okay,
Yeah, which requires steroids and all those things.
right.
So that's it.
Okay. So this is a slide of the other side effects which we can find with Lynparza in the Solo 1 study. Nausea, 77 patients out of 260. Fatigue, asthenia, 63 patients. Vomiting, 40 patients. Anemia, 23. Diarrhea, 34. So all these are the common side effects. I think does that sound in a clinical practice, Shivam?
Yes, sir. Pretty same in the clinical practice. This is what we see generally. Yeah. No changes, sir.
Okay, yeah, because that's what we see in nausea, fatigue, and all is quite. I think fatigue is also very important
Major.
symptom which we try to ignore sometimes in our clinical practice. But that's because that affects the quality of life of the patient to a great extent, and it is very difficult to treat fatigue. Nausea, vomiting, you can treat with antiemetics. Anemia, you can treat with blood transfusions and other factors, growth support. But fatigue is one thing which is quite difficult to treat and can impair the quality of life.
I feel, sir, also fatigue is very underreported in our practice because Indian patients have a lot of domestic help and all kind of relatives to help them. So maybe it is more reported in the Western versus reported in us. But if we ask the patient, there's a lot of fatigue they complain of.
But Shivam, I feel, we normally do not ask about fatigue also.
Yes, sir. Yes, sir. We don't ask.
We don't normally, we ask about
take it for
nausea,
granted.
vomiting, hair loss, we ask about all
Yes.
that. But I think fatigue somewhere, I feel, goes underrepresented. That's
Yes,
what I
sir.
feel.
Yes,
know.
sir.
Dr. Sekhar, what do you think? Is fatigue a common thing which you ask, or do you think that's
No, sir, it is one
underreported?
of the common finding with the PARP inhibitor. We often ask, and most of these patients are young females, and they are on working women also there. I have a couple of working women, and they especially complain of this side effect fatigue when they doing work on all those things. It is commonly seen in practice. But
Right.
thankfully, one thing is that doesn't require dose reduction or dose modification. I encountered only one patient where I intended to reduce dose with fatigue. Otherwise, dose discontinuation or drug stoppage is not seen with fatigue.
I think we are more keen to reduce the dose because of objective things like your anemia, your WBC low.
No,
We are
sir.
more keen to do that. The
Yes.
non-objective, like subjective symptoms, we are not very keen to reduce the dose. Am I
No,
correct?
sir. No, sir. In that patient, she was very subjective for the fatigue. After dose reduction, she definitely felt all right. And that patient particularly tolerated the 300 mg BD dose for almost 9-10 months. So that is the point I decided to come down on the dosage so that after dose reduction, she felt really better. And
Right.
so we continued with the dose reduction.
So this is about nausea, that, it was only an early event and major of the cases resolved without need for a dose adjustment. We know how to treat nausea in the clinical practice. Fatigue, again, we have discussed. The median time to fatigue is about 22 days in the clinical trials. Vomiting was 44 days, nausea 4 days, and anemia was 59 days. And again, they resolved over time. So fatigue resolved over, since 5 to 6 months, as compared to the other anemia about 2 months or something. This was about a fatigue. Majority of the patients did not require any intervention to remain on treatment, but the fatigue recovered on its own. But it was quite significant. 63% of patients had reported fatigue, and dose interruption was happening in 12% of patients. Solo one trial because of fatigue, reduction 9%, and dose discontinuation in 4%. So there was some treatment interruption because of fatigue as well. These are the different management strategies for fatigue and asthenia. Because I think it's very what you call variable symptom. It's not that everybody will, because it all depends on your physical fitness and a lot of other things, what treatment you have received in the past. So it's not like one shoe size fits all. And it is a bit between a liaison between the clinician and the patient to decide what is best for them. The gastrointestinal adverse events, Shivam, what are the most common gastrointestinal adverse events you see in your practice?
Sir, gastritis and stomach pain. Majority of them, they complain of aching stomach pain as soon as I increase the dose. And they say that once they reduce the dose, the pain goes away. A lot of gastritis is second, what they complain of, and dyspepsia. These are three major complaints that they come with.
Darshit?
Hello. Yes, sir.
Darshit, what are the most common gastrointestinal side effects of nolaparib?
Sir, nausea predominantly.
Nausea.
If you are nausea and gastritis, sir, predominantly.
And Dr. Sekhar?
Sir, nausea and nausea, some and altered sensation. Sometimes, very few cases I encountered vomiting, but not I have not encountered any patient complaining of constipation or diarrhea.
What about taste?
Yeah, altered taste sensation. Second most common, nausea, altered taste sensation. Sometimes I've encountered with vomiting. Hardly I've seen any patients with complaining of constipation or diarrhea.
So, taste, I think about grade 1 to dysgeusia was in solo about 26% of patients. In all the studies, about 16, 20% of patients. I think that was again because patients do complain of lack of taste. And that is again one thing which we do not really give a lot of thought to. especially. So I think that's one thing which we may have to start thinking about. And these are the few strategies like adjusting food temperature, adding sweet flavors to bitter foods, using saliva substitutes, rinse mouth while the baking soda solution, good dental hygiene. So, and again, finally, if nothing works out, then reduce the dose. Again, that is the diarrhea and constipation again can happen. More common is diarrhea rather than constipation, and but we all know how to treat that. So, I think these are manageable quite easily, right? And I think any other side effect which anybody's encountered, which you'd like to share, Darshit, Shivam, or Dr. Sekhar?
So one rare side effect, which I explained earlier, sir, interstitial lung disease, and
Yes.
one case of DVT, and these are the two rare side effects encountered with the PARP inhibitors.
But how do you know DVT was because of olaparib?
Sir, the patient is on olaparib. I can't put a causal relationship with olaparib. Maybe most of the patient coming here are having long travel history also there. Maybe that is also a causal factor. But one patient with olaparib I have encountered with DVT, but ILD was there. That is with olaparib.
So ILD, I can still, put a, because it's not very common. So you can say that it's because of the drug which has happened. But DVT can happen in oncology patients, especially if you have ovarian cancer.
So that patient actually completed adjuvant therapy on
Right.
olaparib for 3 months. On the time of olaparib, after 3 months, she had this DVT. It is very
Right.
rare. We have used for multiple patients. That is what I'm not very sure about the causality, but I have
Right.
seen one patient with PARP inhibitor with DVT as a side effect.
Shivam, any untoward side effects which you have seen?
No, sir, I think fairly discussed all of them. No other side effects.
And Darshit? So I think from the side effect, managing the toxicity, I think we have discussed most of the common side effects. So I think if there are no more questions, then I would end this panel discussion. And I would request, I think, Dr. Muzammil Shaikh to give his talk. Thank you, Dr. Sekhar, Dr. Shivam, and Dr. Darshit. I don't think so, Dr. Dev was able to join, but let's go over and hear what Muzammil has to say about the paradigm shift in the management of ovarian cancer. Is Muzammil there?
Yeah, Sandeep, you can hear me?
Now we can hear you, Muzammil.
Hi, nice to see you conducting
How are
the
you?
panel really well. Somehow
Yeah.
I am not able to on my video because the host has blocked me from
No, sir, we have made your course, so you can start your video.
login start. They're saying you can't start your video because the host has stopped it.
Yeah, the host
So just
is.
allow us some time, sir. We'll make your course.
Anyways, so I think I will try. Can I share my presentation from here if possible?
Yes, sir, you can do that, sir.
Is my slide visible?
Yes, sir, it is visible.
Okay. Right, I'm also visible now. Good.
Yes, sir.
Okay.
Are you facing any problem?
No, am I on the full screen mode?
No, sir. So you can make it in presentation mode, sir.
Yeah, looking at that, but There's some technical issues. I'm not able to.
Sir, if you want, we can share your slides.
Please share.
Yes, sir. Dishant, can you please place the slides? Yes, it is visible. Over to you, sir.
Yeah. So good evening. I will just run through the what has changed in ovarian cancer management in last 1 decade. Shift the slide, please. So I'm going to discuss this topic under 4 or 5 subheadings: local scenario and the unmet need, which we should know for all the tumors before we start discussing. The role of BRCA in ovarian cancer, and this is imperative for the oncologist. Olaparib in the first line management, Lynparza in relapsed ovarian cancer, and a few slides about managing the AE. Some has been already covered by Sandeep. Next slide. Next slide. So this is the incidence and mortality of ovarian cancer overall. In incidence, it is 18th in the world, and mortality it is 14th. Next slide. Coming to the India fact sheet, ovarian cancer has definitely increased in last decade or two. Now it is the third commonest cancer in females, and as far as all sexes goes, it's around the 9th cancer which we see. Next slide. So there definitely is a significant unmet need for the newly diagnosed ovarian cancers. The treatment options for almost 4 to 5 decades has been platinum-based chemotherapy. Earlier it was endoxifen, then platinum, taxane, kept on adding one agent after the other. And eventually bevacizumab was the first drug which has shown some PFS benefit. And after that, there was a period of no new additions. And clearly 70% of the patients will relapse in next 3 years of first-line treatment, and a 5-year survival rate of 38%, which clearly needs some improvement. Next slide. And this is the classical story of an ovarian cancer patient based on the CA levels. The first line post-surgery, either it is a neoadjuvant, which is more common in our cases, or adjuvant. Post-surgery chemotherapy, the first line PFS is around 18 to 19 months. And then progressively, it keeps on decreasing from second line, third line, fourth line, and fifth line. So this is true for ovarian cancer patients. Each subsequent lines of therapy, the duration of disease control is definitely lesser. Eventually, it culminates into bowel obstruction and death. Next slide. Next slide, please. Next slide. So some terminologies about BRCA mutated. What do we mean by that? Patient with BRCA1 and 2 mutations, by the virtue of having either deleterious or suspected deleterious BRCA mutations in either the blood or the tumor sample, called as germline or tumor or the somatic. The germline BRCA mutations are inherited BRCA mutations detected by blood or saliva in the samples, called as GBRCA. The somatic mutation or de novo are detected in the patient tumor, which is known not to be a germline BRCA mutation, called as SBRCA mutation. And the TBRCA is for the BRCA mutation detected in the tumor cells. Then there are some non-BRCA mutation. Patients with non-BRCA mutation status have been tested, but do not have a deleterious or suspected deleterious mutations. Patients who have not yet been tested and thus do not have a BRCA status known are called as BRCA unknown. Next slide. So BRCA basically is a tumor suppressor gene, BRCA1 and 2. It is a part of a complex that repairs the double strand breaks in DNA, and it maintains genomic stability in all human beings. They encode proteins which are involved in repair of DNA double-stranded breaks via homologous recombination pathway. So functional BRCA protein regulates cell growth and prevent abnormal cell division, which will otherwise lead to a tumor development. Next slide. And hence, it has become now a part of testing in most of the guidelines. The NCCN guidelines, recent one, says that patients with ovarian cancer, fallopian tube cancer, cancer of primary peritoneal should have genetic risk evaluation and germline and somatic testing, if not previously done. Next slide. The same is reflected by ESMO-ESCO guideline, the ASCO, the SGO, the Society of Gynecological, all recommend testing for BRCA mutation upfront at diagnosis. So this is what we have to offer, and this is what we have seen now. The testing has improved in our country also. something which we are observing, and Sandeep is there and others can comment, that we are seeing a little bit more possibly BRCA mutation than what is reported in other literature. Next slide. And this is the incidence. Approximately 15% of the ovarian cancer patients, a germline BRCA mutation will be found, and additional 5 to 7% may have a somatic BRCA mutation. Next. So this approximately accounts for around 22 to 24% of the patients having some form of targetable abnormality in these patients. However, approximately 40% of the patient with BRCA mutation may not have any relevant family history, and this puts the point forward that use of family history, age, and histology type alone for patient selection in BRCA mutation testing would miss a significant proportion of cases, and hence now all the guidelines do include testing for BRCA mutation at upfront irrespective. Next slide. And it's only the tumor BRCA testing that enables detection of both the germline and the somatic mutations, obviously. And in women diagnosed with ovarian cancer, any BRCA mutation will be present in the tumor cell, whether it is a mutation in germline or somatic. Next slide. This we can skip for the benefit of time. Next slide. Next. So we start with the clinical data. Before we go to the data, we just understand the basic mechanism, how PARP inhibitors work. They exploit something called a synthetic lethality in tumors with a dysfunctional homologous recombinant repair. And this is the deficiency in tumor cells where they will not have a homologous recombination repair where the normal cells will have. So a PARP enzyme required to repair single-stranded DNA breaks in all normal cells. A single-strand break is sealed by this PARP inhibitor by repair by a base excision pair, or a double-stranded is repaired by a homologous recombination. So these are the two mechanisms. Next slide. And in the tumors which are deficient or non-functioning homologous recombination, this will have a synthetic lethality. If PARP is inhibited because of the non-functional HR, they will have a cell death, accumulation of double-stranded DNA strands, and there will be a cell death. So coming to the data, next slide. SOLO was a landmark trial. It was the first phase 3 trial to investigate maintenance therapy with PARP inhibitors in newly diagnosed ovarian cancer. Just click once more, next slide. So it was newly diagnosed FIGO stage 3-4 high-grade serous or endometrioid ovarian cancer or primary peritoneal or fallopian tube, germline or somatic mutated patients, ECOG performance 0 to 1, cytoreductive surgery done in a clinical complete response or partial response after platinum-based chemotherapy. They were randomized 2:1 to receive olaparib 300 milligram BID or placebo. This was continued for 2 years treatment if no evidence of disease. Just click once more, next slide. And this study treatment was continued till disease progression. Patient with no evidence of disease at 2 years, they stopped the treatment, and those who had some partial response at 2 years could continue therapy. The primary endpoint was investigator PFS. Secondary endpoint was PFS by using a blinded independent central review, PFS2, overall survival, and time to subsequent randomization death, and time from subsequent treatment second line. Health-related quality of life was also a FACTO score. Next slide. And these are the baseline characteristics, very well matched between the olaparib and placebo arm as far as platinum sensitivity is concerned, performance status, primary location, and the FIGO stage. Most of them were stage 3 to stage 4. Next slide. Next slide. So upfront surgery, almost more than 2/3 were upfront surgery, which is a little bit converse of what we see in our clinical practice. We see more of neoadjuvant in our clinical setup. Maybe it is the type of cases we get in our clinical practice where almost all are stage 3 and stage 4 here, and plus the surgical expertise across the board. Possibly we are dealing with neoadjuvant first in 2/3, and 1/3 will be interval reverse of it. But it was very well balanced in this particular trial. Next slide. Next. And this was the data. You can see very clear early separation of the two lines. And this was a 5-year update. The PFS benefit was derived earlier in the 2-year update, and also 5-year update. Olaparib sustained a benefit over 5 years. The median PFS was 56 months versus 13.8 months, with an hazard ratio of 0.33, which is impressive by all imaginations. And the follow-up was 4.8 for the olaparib and placebo 5 years. So clear separation, and still there is a wide separation at the end of 5 years. We recently have the 7-year data. Next slide. So 60% of the patients on olaparib arm remain progression-free at 3 years interval versus 27% for the placebo, a definite significant addition as far as PFS is concerned. Next slide. And this was, consistent across all PFS subgroups, whether it is age, the type of BRCA mutation, the baseline CA values, the performance status, the stage of the disease, and even the debulking surgeries. Next slide. Next slide. Next. And it was the efficacy, go back on, and the efficacy was not only across one endpoint, it was at many endpoints. So median time to first subsequent therapy, 51 versus 15 months. Median PFS2 not reached versus 41.9 months with a hazard ratio of 0.5. Median time to subsequent second therapy or death, again not reached versus 40.7. The median OS at this evaluation was immature. We'll come to that later. Next slide. And this was the 7-year follow, which was reported in 2022. It was a paper in ESMO and then ASCO later on. So 67% of the olaparib patients were alive at 7 years versus 46.5 of the placebo with a hazard ratio of 0.55. Of to note is that 44% of the patient in the placebo group, they received subsequent PARP inhibitor therapy, and compared with 14.6% in the olaparib. So this definitely is a very significant, value. Next slide. And regarding the dose interruptions, around 11.5% patients in the olaparib arm discontinued treatment due to an AE. So on subdividing, dose interruption was seen in 51%, dose reduction was seen in 28%, and discontinuation was seen in 11.5%. Understandably, this drug is not without side effect, but usually, well tolerated. We have discussed in the panel also how to tackle this particular issue of drug reactions in PARP inhibitors. Next slide. And most common side effects of, Shivam was mentioning about asthenia and fatigue. We don't ask for in our clinical practice, but yes, asthenia and fatigue, grade 3 was seen in around 4% of the patients. Other thing which bother us is nausea. Fortunately, most of them is grade 1 or 2, very well managed with simple antiemetics and antacids. Anemia is significant. Around 22% will have a grade 3 or 4 anemia, which requires dose modification and sometimes dose, really reduction of dose. Diarrhea is bothersome only in a few percent of patients in our clinical practice. Neutropenia is, in our practice, we don't see so much. But yes, as per this trial, it was 8.5, had a grade 3 to grade 4 neutropenia. Next slide. Some AE of special interest, the propensity to cause MDS AML in olaparib arm was 1.5 versus placebo 0.8. New primary malignancies was 5.4 versus 6.2, and most was comparable. And most of these were actually CA, breast, oral cavity cancers. ILD was shared more in 1.9 versus placebo. So this is what we also watch for when we are giving this patient for a longer period. Next slide. There were no clinical meaningful difference as far as the health related quality of index parameters were concerned. And, it was very well tolerated, didn't disturb the quality of life of patients. Next slide. Coming to another important trial called as Paola trial, Paola 1. This is treating non-BRCA mutated patients. Olaparib in newly diagnosed patient treated with chemotherapy and bevacizumab. So these were all same subgroup of patients, stage 3, 4, serous or endometrioid or non-mucinous BRCA mutated, surgery upfront or interval, platinum taxane-based chemotherapy, and at least more than 3 cycles of bevacizumab. Based on whether they have got an NED, CR or PR, they were randomized to olaparib plus bevacizumab into 2 years, olaparib and bevacizumab for a year, or placebo into 2 years plus bevacizumab. The primary endpoint was investigator-assessed PFS, and the secondary endpoint was the time to subsequent therapies, PFS2, OS, safety, and quality of life. Next slide. And again, we'll not spend more time here. Just to highlight that as far as the tumor BRCA mutation status was concerned, these two arms were very well balanced. The tumor BRCA mutation was seen in 30% of the arms, and no tumor BRCA mutation was seen in 70%. The subsequent patient, there was no tumor BRCA mutation. All other parameters were very well balanced. Next. And this was the reason for discontinuation, and obviously disease progression was the most commonest cause for the stopping the treatment. Very few had to stop the therapy because of the side effects. Next slide. Next slide, please. And this was the graph for PFS. Olaparib plus bevacizumab significantly improved the PFS versus placebo plus bevacizumab. And this is in the intent to treat population. We will see the subset later. So very clearly 22.1 versus 16.6 months, a 3-year follow-up, and hazard ratio of 0.59. So this was definitely, gain of, adding the doublet in the patients who had, either BRCA mutated or even non-mutated. Next slide. Next slide, please. And if you see the subgroup, the intent to treat we just saw, it was the PFS was 0.59. Difference in the median PFS was 5.5 months. So definitely a 5.5 months addition in the entire population. When we subdivide this to tumor BRCA mutation positive, the difference becomes very large. It is 15.5 months, and the hazard ratio is 0.31 for the PFS. If we add HRD positive to this, 19.5 months difference and 0.33, just to bring to the to the audience that nowadays we are doing HRD positive status in most of the ovarian cancers, which are not just relying on testing for BRCA1 and 2. So practically most of the labs are doing, and we are trying to get the HRD status known. Next slide. And in this forest plot, we can very clearly see that the benefit of adding olaparib to bevacizumab was across all the subset, whether it is age less than or more than 65, FIGO stage, debulking surgery, type of debulking surgery done, whether it was upfront or interval cytoreduction, and also to the response of therapy. Next slide. Next slide, please. And this is the 5-year overall survival data. Olaparib plus bev proved a clinically meaningful improvement in the HRD positive patients. It was, at median OS was 75.2 months versus 57.3, and the 5-year overall survival rate was 65.5 versus 48.4, and the hazard ratio for OS was 0.62. So clearly 38% reduction in risk of death for olaparib plus bev versus bev alone. Of note is that patients receiving a PARP inhibitor during any subsequent therapy, for olaparib bev, it was 17%, while more than 50% of the patient on the bev with placebo arm did eventually receive a PARP inhibitor. Next slide. Next slide, please. And there was nothing very unusual in this when you're giving a combination. Of course, when you're adding bevacizumab to olaparib, what we have to watch for is hypertension. Anemia was always more in those group who received PARP inhibitors. We know how to manage. We'll discuss that later. Lymphopenia was also seen in few percentage of the patient, and GI symptoms were seen. Some did complain of fatigue. Next slide. So to sum up, there are two landmark trials which we should be, aware of, and this will sum it up. Paula 1. This was the 5-year follow-up data, 2022. It is the only phase 3 randomized trial to investigate the addition of a PARP inhibitor, olaparib Lynparza, to active treatment with bevacizumab in newly diagnosed setting with the intent of achieving maximum therapeutic benefit. And what were the findings? 3 times longer median PFS, 46.8 versus 17.6 months in favor of Lynparza plus bev. Almost 1 in 2 patients remain progression-free at 5 years with a hazard ratio of 0.41. 2 out of 3 patients are alive at 5 years. And at the final OS analysis, olaparib added to bev substantially improved PFS versus bev alone, and a 30% reduction in the risk of death versus bevacizumab alone. And of course, it laid the foundation for doing an HRD testing. The second trial, which we should remember, is Solo 1, and this was the 7-year follow-up, which is, I feel, a very large follow-up for a disease like ovarian cancer. And 2022 data, first PARP inhibitor demonstrate clinically meaningful overall survival at 7 years follow-up. 2 out of 3 patients are alive at 7 years. 1 in 2 patients yet to receive subsequent treatment at 7 years, and laid the foundation for testing HRD and consistent safety profile in as was expected in these trials, which use PARP inhibitors. Next slide. So what's the data for the relapsed ovarian cancer, platinum sensitive? Next slide. So this was SOLO-2 phase 3 treatment study for treatment of maintenance with olaparib in patient with BRCA mutated high-grade serous ovarian cancer, similar subset of patients who have relapsed following 2 prior lines of platinum-based chemotherapy. They have achieved a clinical PR or a CR following completion of the last platinum-based chemotherapy. Minimum 4 cycles should be administered, good performance status, documented BRCA mutation, or patient willing to consent for testing for deleterious mutations were included. They were randomized within 8 weeks of the last chemotherapy dose in 2:1 ratio. The stratification was based by previous platinum responses, time to disease progression in the penultimate platinum-based chemotherapy, either to olaparib 300 BD or placebo. The primary endpoint was PFS, secondary was PFS2 and the OS. Next slide. And the demographics were very well balanced. We'll not go into details of this. Next slide. Next slide. Yeah, so this is the graph which showed about the difference in PFS when we compared placebo versus olaparib. Very clearly, the median PFS 19.1 month versus 5.5, hazard ratio of impressive 0.30. So these results confirm the findings from the study 19, which was a similar study, and provided further evidence for olaparib in platinum-sensitive high-grade serous relapsed ovarian cancer. Next slide. This was the PFS which continued and consistent beyond the progression. So the significant improvement in PFS2 at the interim analysis has been demonstrated despite relatively few events and patient crossover. So the median PFS was not reached in the olaparib arm versus placebo. It was 18.4 with a hazard ratio of 0.50. Next slide. So other secondary endpoints, time to first subsequent failure 27.9 versus 7.1 with hazard ratio of 0.28. Time to second PFS or PFS2 not reached versus 18.4, and time to second subsequent treatment again not reached to 18.2, hazard ratio of 0.37 in favor of PARP inhibitor maintenance. Next slide. So olaparib maintenance therapy showed a clinically meaningful improvement in OS versus placebo, and this was the 5-year data. The median OS 51.7 versus 38.8 with a hazard ratio of 0.74. And also to note is that 38% of the placebo patients and 10% of the olaparib subsequently they switched over to a PARP inhibitor therapy. Whether this was a data which has censored these patients, I'm not sure. But it did have a significant impact. Next slide. So the median total duration of treatment in SOLO-2 was 19.4 months in the olaparib arm. At every, say if you see 6 months or 12 months, there is tripling of the, it's over 3 times benefit. At 6 months, it is 44 versus 80, and at 12 months, 21 versus 62. At 18 months, 17 versus 52, and at 2 years, 13 versus 45%. Benefit in the favor of olaparib maintenance. Next slide. So the adverse events generally are well managed. We recognize early. We know how to manage. So we are able to manage it with some dose reduction in significant. We'll come to that later. Next slide. And these were the commonest AE on olaparib: nausea, anemia, and fatigue. Next slide. Next slide, please. Next slide. And this was an Indian study where it has shown that even our subgroup of patients, olaparib was very well tolerated. This discussion we had in the previous panel also, that most of us are giving not 600 but around 450. Some are also happy with 300. So we are giving a dose lesser than what the trials have recommended. Next slide. Next slide. Yeah, coming to the AE management strategies, we have to support and patients proactively during the first 2 to 3 months, which is most important period, I feel. Manage the patient's expectation pre-treatment, reduce the impact of AEs, proactively monitor the AEs so that we can do an early intervention. And to manage low-grade AEs, just symptomatic management. And for higher grade AEs, we do dose interruption first, and then we do a dose modification if required. Next slide. So for concurrent medications, we should be very careful because many of these are elderly patients with many comorbidities. So we look for potential interaction like CYP3 inhibitors or inducers. Renal functions, many will have hypertension, diabetes, cardiac issues at this age. So mild impairment renal function, dose, no dose modification, moderate if the creatinine between 31 to 50. We have to reduce the dose of olaparib by 1 dose. That is given in the booklet also. Doing full blood counts and monitoring it, and monitoring the liver function is also very imperative. For mild liver dysfunction, there is no dose modification required. For severe liver dysfunction, this has to be avoided. Next slide. So dose interruption, the recommended dose, toxicity requiring dose interruption. If the toxicity resolves, you can, less than grade 1, you can again resume at the previous. If again it occurs, grade 2 or grade 3, then you should possibly reduce the dose. So we have to explain to the patient that dose reductions are generally implemented as a secondary approach to toxicity management when other methods have failed, like a dose interruption. Next slide. And these are the commonest AEs of patients on olaparib: gastrointestinal disturbances, fatigue, and anemia. If you see prevalence of nausea grade by month, so you very well adapt. In the first 3 or 4 months, you have to keep a more closer watch. After that, it is quite fairly static as far as the incidence is concerned. Same is for anemia. However, I feel that anemia over a period of time sometimes can become bad, especially after 5 or 6 months of olaparib therapy. Next slide. Next slide. So for simple management, nausea, we can very well manage. There are so many potent anti-emetic drugs. Anemia, we keep a close watch. Fortnightly we do, and if required, we transfuse if it is symptomatic anemia, or dose reduction if it is more than 3 to 4. Fatigue, and this is the commonest reason where we go for a lower dose around 450. Fatigue is seen in many patients actually. So I think in our subsets also, fatigue is a very common finding. Dose modifications for fatigue is not very common. We are maintaining most of the patients on 450. Maybe that takes care of the fatigue part. Diarrhea doesn't bother us much. We have drugs which are much more toxic as far as diarrhea is concerned, and we are comfortable using them also, like the TKIs. Next slide. So these are the dose. The recommended daily dose is 150 milligram, 2 tablets twice a day. First dose reduction is 250 milligram twice a day, which is 150 milligram 1 tablet and 100 milligram 1 tablet taken twice. And the final dose reduction is 200 milligram twice a day. In our practice, sometimes we give 150 milligram 201, which becomes 450 milligram. Quite a few patients are comfortable on this. Next slide. And this is the dose reductions over a time. So once the first 3 or 4 months are over, there is a quite good tolerance. We don't really modify the doses in most of the patients. Next slide. Previous slide, please. So it is easy to manage the AEs, understand the potential AEs associated with the use of olaparib and the trajectories, put strategies for management in place and start early. Patient education is key. Manage the expectations upfront, and most AEs can be managed by symptomatic treatment, dose interruption, delays, or sometimes dose reductions. Thank you. Any questions we can take?
Thank you, Muzammil. That was a very comprehensive talk from your side, and fantastic. Thank you very much. I think we have come to the end of the session. If there are any questions from any one of the members, the panelists, please feel free to ask now. Otherwise, I will hand over back to the organizers. And thanks once again to Darshit, Muzammil, and Dr. Shaikh and Shivam for participating. Thank you very much. Good night.
Good night, Sandeep.
Good night. Good night. Take care. Bye.